Judges, welcome back. As we have in the past presentations, judges will have you introduce yourselves and then we'll hand it over to the team.
Okay, I'll go ahead and start. My name's Kim King. I'm the president of Strategy Advantage. We're headquartered in Los Angeles. We specialize in growth strategy for hospitals and health systems. That means that on a day-to-day basis, my team and I are doing market expansion, enterprise growth strategy, et cetera. So this is really right up my alley. I spent the first 10 years at Cedars-Sinai here in LA, working in executive positions there. Started the company in 2002. We're now about a 20-person team, and we're doing our work across the country, but we know the California market very well. So it's nice to meet you all. We can't wait to hear your presentation, and good luck to you.
Thank you.
Hi, good afternoon, everybody. My name is Victor Carrasco. I'm the CEO for East Los Angeles Doctors Hospital. We're a safety net hospital in East Los Angeles. We hold capitated lives in our system, and very excited to be here and listen to your presentation, as this is something that we do every single day. So looking forward to your strategic analysis and your reviews.
Thank you.
Good afternoon, everyone. Dimitris Alexio here, President and CEO with the Hospital Association of San Diego and Imperial Counties, and really excited to hear your presentations. Always love hearing the thoughts and ideas that all of you come up with, and kudos to all of you for taking the opportunity to participate in this competition.
Thank you.
Yeah. Team Inland Empire, good afternoon. I'm Mark Lisa. I'm the Chief Executive Officer of Tenet Health Central Coast, a 2-hospital market in San Luis Obispo County. Happy to be here today, and excited to hear your presentation and help you devise the solutions that we need. So thank you and good luck.
Thank you.
Good afternoon in Empire. I'm Evan King with Copel Solutions. I'm a principal based out here in Los Angeles. Our firm focuses on value-based strategy, working with health systems and payers to align on how to improve performance to manage risk of all ranges. This case is close to me. It was an engagement I worked on a few years back with our clients. So excited to hear your thoughts. Not an easy one. So looking forward to your creative solutions, your assumptions, and how you came to a conclusion. So looking forward to today. Thank you.
Thank you.
Thank you.
I'm Bonnie Penlasigi. I'm the Chief Operating Officer at St. Mary Medical Center in Long Beach, California, part of Dignity Health and with Common Spirit Health. And looking forward to hearing your presentations today. It's something that I wished I could have been able to do when I was a student out in the East Coast for grad school. So kudos to you guys for taking the initiative to do something like this. So looking forward to hearing your presentations.
Thank you.
Thank you.
Thank you, judges. Inland Empire Consulting Group, the floor is yours.
Thank you. Good afternoon, everyone. Thank you for attending our presentation today. We are the Inland Empire Consulting Group. My name is Thomas, and I will now invite my team to introduce themselves.
Good afternoon, everyone. My name is Zainab.
Good afternoon. My name is Miriam.
Before we dig in, here's a brief look at what we will be discussing today. We will summarize our strategic plan and then delve into our analyses, strategic propositions, and recommendations for implementation and evaluation. The question posed to us in this case is whether expansion into the Inland Empire is strategically appropriate for the system described in our case, which we will refer to as Health System X. We identified 3 key health issues within the Inland Empire: care coordination, quality of care, and accessibility. Our strategic proposition will require partnerships with local mission-aligned hospital systems, health plans, and physician groups presently established within the Inland Empire, the subsequent creation of an accountable care organization, and the development of outpatient care facilities. The impact of expansion into the Inland Empire will lead to care coordination of 200,000 Medi-Cal and Medicare lives, the acquisition of 160 healthcare providers, and the development of 20 ambulatory care facilities. The projected operating return on investment will be upwards of $120 million. During our analysis of the Inland Empire market, we saw that the Inland Empire is experiencing substantial population growth, with the largest resident demographic being the Latinx population with 51.6%. Residents in the Inland Empire have been known to have poorer health outcomes compared to California's statewide averages. Although patient visits have increased, the Inland Empire is still only at half of California's average patient visits. In looking at the local market trends, we noticed several strategic partnerships in the region. Blue Shield with Prime Care, Optum Care with Prime Care, and Loma Linda University with Riverside University Health System. According to our scan, the major competitors with footholds already established in the region would be the Kaiser Permanente's Health System, Dignity Health System, and Universal Health Services. The reason that the Inland Empire averages are lower than the California statewide averages is largely attributed to the highly fragmented and unconsolidated healthcare market and the lack of patient care coordination, which in turn leads to poorer health outcomes. This fragmentation has historically been seen throughout much of Southern California, including Los Angeles and Orange counties. However, these neighboring counties have already begun addressing these issues that are still prevalent within the Inland Empire. Now let me introduce you to Maria, an Inland Empire resident. She's a 48-year-old Medi-Cal patient whose medical history includes type 2 diabetes, high cholesterol, and coronary artery disease. So what does the current care process look like for Maria? In August of 2018, Maria began experiencing shortness of breath and made an appointment with her primary care provider. After spending 5 minutes in the PCP's office, she was prescribed Lipitor for her high cholesterol and sent on her way. 2 months later, in October, Maria began experiencing chest pain and shortness of breath once again and made an appointment with her PCP. Her PCP then referred her to a cardiologist. Her visit with the cardiologist took place 4 months later in February of 2019. This visit prompted them to address her coronary artery disease with an angioplasty procedure. She was then sent to 2 different diagnostic facilities for blood testing and x-rays. In April, Maria underwent the angioplasty procedure, but unfortunately developed an infection 2 weeks later, which sent her to the emergency room after failed attempts to reach her PCP. Throughout July, Maria recovered from her infection. As we can see through Maria's care journey, she had to visit 6 different facilities, manage her own healthcare records, schedule and maintain her many care visits, and was ultimately left feeling uncared for by her providers. From the time she began experiencing symptoms to when she had fully recovered was nearly a year-long process. I will now pass it off to Zanab to discuss our value proposition and strategy to ensure that other patients within these safety net populations do not have to endure what Maria experienced in her journey of care.
Thank you, Thomas. After analyzing various factors such as market share and key affiliations, we have determined that partnerships with Loma Linda University Medical Center, Arrowhead Regional Medical Center, and Riverside University Health System Medical Center would be advantageous. Based on our market scan and analysis, we believe that the value Health System X will bring to the Inland Empire will be based on the experience with Medi-Cal safety net populations and improving community wellness. This is especially valuable for the Inland Empire as Medi-Cal and Medicare populations continue to grow. Their experience will allow local community-based health systems to meet the increasing needs for care coordination and to ultimately decrease costs of care. The first priority in establishing a foothold in the Inland Empire is to partner with the physician group to provide primary care providers. Our research on the independent physician group Prime Care is the optimal choice as it is one of the largest medical networks with 350 providers and 14 IPAs. Prime Care is currently affiliated with Optum Care, another growing health network within the Southern California region. The next step is creating a partnership with established health systems such as LLUMC, RUHS-MC, and ARMC. These 3 health systems are safety net providers within the IE region, provide care through specialists, and have missions and visions aligned with uplifting underserved populations. Alongside these characteristics, these health systems have profound name recognition and are largely trusted within the area. Now that partnerships have been established with the physician groups and health systems to attain primary care providers and specialists, creating an accountable care organization would address issues of accessibility, care coordination, and increased quality of care, with the patients remaining the main focus. To provide services for our patients, we believe it is important to establish outpatient clinics in densely populated areas that do not have easy access to healthcare facilities. We believe that the southwestern areas of the Inland Empire are prime locations for outpatient facilities. After we have determined where our outpatient facilities will be placed, we can now focus on acquiring patients to be seen under our ACO's umbrella. We believe that it would be strategic to create a partnership with the Inland Empire Health Plan, also known as IEHP. IEHP currently has over 1.3 million covered patients, is one of the largest managed care stakeholders within the Inland Empire, and has established contracts with half of the region's PCPs and specialists. IEHP already has a deep understanding of utilizing a value-based care model and has established a pay-for-performance initiatives. The second health plan partnership would be with Molina Healthcare, which is a private company providing low-cost healthcare and manages a portion of the managed care market within the Inland Empire. Both health plans' values are based in providing the highest level of care to Medi-Cal and Medicare patients within the Inland Empire. I will now pass it on to Miriam to discuss our strategic recommendations and gauge success over time.
Thank you, Zainab. As my partner just outlined, we suggest forming various partnerships. The proposed ACO structure displays strategic partnerships between established physician network groups, health systems, and health plans, which enable the ACO to coordinate care between patients, providers, and health plans for the Medi-Cal and Medicare populations. Our analysis of the Inland Empire population demographics and the market share of IEHP and Molina Health has determined that attaining 40,000 members per year would be feasible and manageable, allowing us to reach 200,000 members by year 5. Based on the current Medi-Cal and Medicare numbers, taking uninsured individuals into account, it is possible to obtain a greater membership number. An additional 10,000 members per year could be enrolled if we were to take a more fiscally liberal approach. Let's see what the process for Maria would have looked like with our proposed plan. In August of 2018, when Maria experienced shortness of breath and made an appointment, her PCP had given her limited time and had sent her off with a prescription. In our value-based model, the PCP and the ACO would have prescribed the appropriate medication, but also spent more time with Maria, listening to her concerns and educating her about an appropriate diet and exercise regimen. Maria then would have received a follow-up call from a nurse practitioner to check in on her progress within a month of her appointment. Upon learning that Maria has been experiencing shortness of breath and some pain, the NP would have set her up with a clinical care coordinator who would have overseen setting up appointments and handling referrals with a cardiologist in the ACO. In the new model, Maria's appointment with the cardiologist would have been at the end of the month, not 4 months out. Her visit with the cardiologist would determine the need for an angioplasty as a solution for her coronary artery disease, and the clinical care coordinator would schedule Maria to have all blood work and radiology scans performed at the same location. In October, Maria would have had her surgery and would have been monitored to make sure that no post-op infection occurs, and an NP would have followed her up with her soon after. Throughout this process, Maria would have received regular follow-up calls, her care would have been managed by a clinical care coordinator, and she would have received the proper resources and education to manage her illness. Returning to our strategy, we believe that expansion into the Inland Empire is the appropriate move for Health System X, considering the many opportunities that the area presents. We have seen that the Inland Empire has a fragmented healthcare market, an increasing population, fewer individuals that have commercial insurance, and a substantial underserved population. LOUMC is a key safety net provider, which would make them an experienced partner. Health System X would also have an opportunity to address the physician shortage in the Inland Empire by recruiting Northern California physicians. And lastly, Kaiser Permanente has already identified this market as a prime location for expansion. Therefore, we believe that Health System X, in partnership with local organizations and associations, can capitalize on this opportunity. Expansion does not come without its risks, and some of these potential risks could include contract disputes, CMS health measures that are not being met, and a low return on investment. A new strategy to partner with the health plan Blue Shield, Health Systems, Dignity Health, or Universal Health Services, or a physician network group, Beaver Medical Group, should be considered if the initial partnerships do not come to fruition. Providers that are unable to help their patients meet health outcomes by the end of the year will receive fewer patients the following year. Low return on investment could be mitigated with a discussion regarding a new strategic plan about shifting locations to neighboring counties such as Imperial and Ventura. To execute our strategy, we have outlined the following implementation plan. In phase 1, Health System X will engage in contract negotiations with the following groups: Physician Network Group Prime Care for their primary care providers, Health Systems, LOUMC, RUHSMC, and ARMC for their specialists, clinical care coordinators, and social workers, health plans IEHP and Molina Health for their members. We will also secure 4 outpatient facility locations, retrofit them into medical offices, and secure medical and office equipment for these locations, preparing them for use for the following year. We will then work with a staffing agency to hire administrative staff for the outpatient facilities. Phase 2 will be an ongoing process as we acquire the specific number of healthcare providers and members per year based on the contracts. Each year, we will secure more office locations for use in the following year. Phase 3 will also be ongoing as each year will evaluate the previous year's metrics and benchmarks. To identify the progress, success, and efficacy of the strategic initiative, we have identified 5 key metrics. Quality of patient outcomes will be evaluated using the CMS standards for patient improvement. Physician performance and patient surveys will allow measurement of patient outcomes and the quality of care provided by the physicians. Population health measures will assess the impacts in the community. Measuring emergency room utilization and inpatient admissions will indicate whether or not patients are receiving timely care from their PCP team. Lastly, as an ACO, the organization will have to spend up to 2 years as a Track 1 ACO in the Medicare Shared Savings Program and collect data and set savings benchmarks to measure the sustainability of the program and qualify for savings benefits from the Medicare Shared Savings Program. I will now hand it back to Thomas to discuss the budget and revenues.
Thank you, Miriam. In developing our financial analysis, we focused on the operating costs since our savings metrics will be based on the ACO's operating structures. For the operating revenues, we expect to see upwards of $30 million, operating costs of roughly $8.3 million, for a net operating revenues of $23 to $24 million per annum. This would bring in an estimated $120.6 million by the end of the proposed 5-year initiative. However, we opted not to include the shared savings returns in our operating forecast since the ACO will need to collect relevant data to identify those cost savings opportunities and set benchmarks for those savings. Furthermore, with the organization breaking into a new market area that is highly fragmented, it will take time to create a culture of care coordination and regain the trust of patients like Maria. We expect that Health System X will be able to materialize those shared savings by the end of year 2 as they transition from Track 1 to Track 2 of the Medicare Shared Savings Program. This means that the net revenues could increase throughout the proposed 5-year initiative. I will now hand it back off to Zanab to conclude our presentation.
Thank you, Thomas. Throughout our presentation, we have highlighted key issues within the Inland Empire and the opportunity to expand and create strategic partnerships across established entities within the area. We believe that our ACO will increase coordination of care for patients, improve the quality of care by implementing a patient-centered approach, increase access to healthcare services by establishing outpatient clinics, and reduce unnecessary healthcare spending by utilizing a value-based care model, which would divert supplemental funding to promote community initiatives. Overall, we foresee this strategic initiative to be beneficial to the health system and the patient population across the Inland Empire. Thank you for your attention, and we will be honored to answer your questions now.
Thank you for your presentation. I very much appreciated Maria's story. Almost curious to see how she's doing, but I definitely enjoyed that quite well. And excellent storytelling skills for Thomas, I believe. That's good to loop that as a good strategy. Curious as to your sort of revenue structure. I saw that over the 5 years, your revenue actually went down. Curious as to what factors you considered for that to occur, and then your cost stayed flat, even though your membership is going to go up. Just curious around those two factors, how you kind of came up with that.
Mm-hmm. Thank you for your question. As we calculated the net operating revenues, they do appear to go down over time. We chose to calculate these using current operating cost trends so as to show a somewhat, pessimistic outlook. As the ACO operates in the first 2 years as a Track 1 ACO within the Medicare Shared Savings Program, they will be able to identify the specific cost savings opportunities and set those benchmarks to decrease costs. And with the larger revenues generated in the first 2 years, along with the resources of the health system and the partners, they will be able to work with the health care provider teams themselves to identify where and how they can cut costs without negatively impacting the quality of care. Obviously, decreasing operating costs will over time increase the net operating revenues. And also with the Medicare Shared Savings Program, the ACO could receive revenues from the Centers for Medicare Services that are currently not factored into these specific calculations.
Thank you.
This is Mark. I liked the flow of your presentation. I liked the Maria story was interesting too. Your flow was logical, and I like the fact that you specifically called out your risk identification and that you eliminated your KPIs. So Yeah, I thought it flowed well, and I appreciate it. It made logical sense to me.
Thank you.
Thank
Yeah.
you.
I just wanted to echo Mark's comments. This is Evan. Again, I think from the get-go, it was clear from the beginning, stated the objective, went into the assumptions, what we're trying to accomplish, and a good process, easy to follow
Yes.
throughout. And again, whether or not we got right or wrong, good assumptions and rationale. So really appreciated the thoughtful approach.
Thank you so much.
I have a quick question, wondering if, as you considered partners and your overall goals and the changing environments of healthcare, et cetera, to what degree did you factor in what I might call non-traditional provider partners? And if so, if you did, who did you potentially consider that would be beneficial to your broad strategy?
I believe Zanab would have an answer for that one.
Yes. So essentially, we were for our ACO structure, we wanted to partner. We wanted to include clinical care coordinators who would essentially refer our patients to different community organizations within the Inland Empire. So, you know, Loma Linda University Medical Center and Riverside University Health Medical Center are affiliated with different community organizations within this area. And these are our stakeholders that we would like to introduce within our patient population to increase the quality of care that we're providing outside of the physician's office.
Okay, thank you.
I also would like to echo the comments earlier about just the organization of the presentation. I appreciated that, and then the story was very good. I also wanted to just make a comment. You know, when you're looking at the analysis of, you know, your primary care physicians and which organizations will have the most for you to tap into. Some organizations do it better than others. And so just kind of look into that. I know it's hard for you to make that those facts because you're making assumptions, but in the future, when you have the hard facts, it's good to partner with those groups that have a strong representation of those PCPs.
Definitely. Thank you.
Thank you.
That's the end of questions. I want to say congratulations and thank you to the Inland Empire Consulting Group. The judges are going to pop into a breakout room to discuss. And those of you who are on the call, keep your audio on. It'll probably be about 5 minutes before we come back to share the feedback with you.
Okay.